Hey everybody, this is Erica Mello, and welcome to episode number 62 of Tough to Treat. And this is a patient of mine who I actually just recently saw, and she has a quote unquote, scoliosis. And does she really have the scoliosis, or does it just look like she has scoliosis is what we discuss. And how do you work with patients who are in their mid 60s who have shin pain and have questions about what their back looks like at that age, and she can't walk more than 10 to 15 blocks without right shin pain. And is it stenosis? Is it something else? Is it her strategy? Is it her motor pattern? And this is a really common problem for people, especially in that age group. And Susan and I clinically reason through my evaluation and certain movement patterns that really help her. And I think we talk a bit at the end, which is really important. So please listen through to the end about movement strategies and what type of patterns and movements work well. And it's not just about releasing and letting them go, releasing soft tissue. I mean, it's really about giving them the right exercise. Why are you giving them this exercise? Clinically reason through their whole movement program. And if someone has 5 minutes for an exercise, you need to pick the best one for them. And it's not just, strengthen your glutes and standing. It's definitely more than that. And you need to explain that to these patients. Anyway, I hope you enjoy it. We'll talk to you soon. Bye. Hey everybody, this is Erica Mello and Susan Clinton, and we are Tough to Treat. And by the time you listen to this, it will probably be, if you're listening to it live when it comes out, it'll most likely be the New Year. So happy New Year, everybody. Happy New Year, Susan.
Happy New Year, Erica.
Oh my Lord. Beginning of a new decade.
Mm-hmm.
Oh my gosh. On that note, I will get going since it's my turn to discuss an interesting patient. Are you ready?
Ready.
Okay, so I will preface this by saying I've only seen this woman twice, okay? And I thought she was very interesting because she has a significant scoliosis. So let me give you her sort of background. She's 67. She used to live in New York and then ended up moving to Denver and came here over the holidays visiting her kids, and came in to see me. And her main complaint was right shin pain. Okay. And she would go sort of around the peroneals, a little bit onto the anterior tib, but mostly she'd run that hand down the lateral border of her lower right leg. And occasionally she would get right glute pain, but it was really mostly the shin pain. And what really aggravated it was excessive walking, not surprising. But then she also told me that if she walked just a little bit, it would feel better. I was like, interesting. And the sitting made it feel better. So aggravated, significant walk. So Denver, you don't walk a ton. At least she didn't. In New York, she comes back and it's much worse because she's walking a lot. And what made it feel better is sitting and just a little bit of walking, quote unquote. Just her past medical history is somewhat significant. She had a laminectomy in 1999. And same issues, right side. She failed 3 epidurals back then. In 2012, her symptoms came back and lasted about a year. And since December of last year, 2018, she started feeling the right leg pain. So laminectomy 1999, she had 3 failed epidurals. 2012, so she had a pretty good run. 2012, she ended up, her symptoms returned after physical therapy for about a year. They went away. So she had some 5 or 6 years of, pretty good function, actually. Then she started to get these symptoms into her leg again in December of 2018. She had 2 epidurals. Once again, no relief there. Okay. She's also suffering from like a costochondritis since October of 2019, left worse than right. And she's also had some issues with her vocal cords. She's had some paralysis of her vocal cords over the past year. Um, about 7 years ago, she fell onto her left side and fractured both of her, like, bunch of ribs. Nothing else significant in terms of past medical history. Her main form of exercise is really, unfortunately, walking for her because she loves to walk. Any questions so far, Susan, or should I keep going?
No, I don't think so.
Okay.
What happened in 2018 when her pain started again? Was it insidious onset, or was she doing something? Was it anything
I asked that.
different?
Yeah, no, I asked that. She said it was insidious, but I will tell you, she fell about a year ago and fractured her left wrist. She also, 2 years ago, fell again and had a left humeral fracture. She has osteoporosis, but nothing that she could pinpoint in terms of why this started up again. I mean, it seems like
Okay.
she gets relief, it starts up again. She gets relief, it starts up again. Yeah, no, I pressed her on that, but she didn't really, wasn't able to tell me. She had some imaging in June of 2019, which showed, I did not see this, but she told me she had a herniated disc and some degenerative joint disease. She's harping on the disc. I have the disc, and I'm like, well, you're 67. I mean, you know, I'm like, I explaining to her, you don't really fit the classic presentation of a hot disc. And she, I don't know if she really accepted that explanation. I was explaining to her, I said, we usually just hate to sit. Not all of them. I said, you don't really,
Mm-hmm.
have a problem sitting. And, I said, you're doing all the, walking is something you need to do because of your osteoporosis. And she basically, the only medication she's taking are cholesterol. So she's pretty healthy, 67, recently retired.
Mm-hmm.
Um, not, the therapy that she was getting in Denver is a lot of, I think, some dry needling, some myofascial stuff as well. Uh, I'm not sure how much movement she's getting, but she's been in therapy probably about a year, I think she said.
Yeah, it
Um,
sounds. It just really starts to sound. Just listening to the presentation at face value, sounds like a lateral spinal stenosis type issue here.
yep,
She likes sitting. She doesn't like long walks. It's not as irritable, so she can do short walks and it feels better.
yep,
But it feels better immediately upon sitting. That's
yep,
generally the presentation of that.
yep. And
So there may be some old scarring around the nerve or something else going on. I don't know what dry needling is going to do, but
yeah, I mean, I don't do it. We can't do it
mm-hmm,
anyway. So, but what she did tell me about a year ago, because I had her in standing, and about a year ago, she literally noticed a significant scoliosis, a significant pelvic shift to the right, and the thoracic shift to the left. I'm like, when did this happen? I took a look at her, and I'm like, whoa. And she's like, yeah, that happened about a year ago. So this is when her symptoms started again, and
mm-hmm,
and so once again, she woke up one morning and all of a sudden she shifted. It probably was happening for years, and it didn't get to the point where she really noticed
right,
it. So I would agree with you there. That's why I was explaining to her. I was like, you may have a disc issue, but it's not the overarching theme here at this
yeah.
point.
No, it sounds more of a foraminal issue to me.
Yes, I would
So,
agree. So not surprising when I took a look at her in standing. Her pelvis was so far right over her feet. It was like out the door. It was really
mm-hmm,
significant. And not surprising, left thorax all the way down
mm-hmm,
from ribs 2 to 10, all the way to the left.
yeah,
Head was pretty centered, but I would say, if I had to sort of give her a center of mass, it was way to the right. Her
mm-hmm,
right glutes were extremely facilitated. I mean, extremely. I mean, to the point
mm-hmm,
where they were like just in standing, turned on all the time, where her left was
mm-hmm,
not. Not makes sense. She's not on her left side. She's not
right,
using those muscles. So I just had her do a right side in standing, and so then I took a look at her hip, just my quick and dirty, sort of pelvis rotation to the left. Her right hip was anterior. Not meaningful. I don't believe in her presentation, but that's how she was. Her right foot was extremely rigid. I mean, she was really supinated, really rigid, did not gripping the ground, and the left foot looked much softer. She had more of that yoga toes. It was much more
Mm-hmm.
like a fan type of a foot, whereas the right was like a fold. It was folding. There was no salsa in her foot. There was no give. So
Mm-hmm.
those were the major objective, just visually, findings that I thought were relevant. Um, what was interesting though is that when she told me at home she would like put a massage ball under her glutes and it would feel better. I'm like, well, it would. I mean, that generally does give you short-term relief if you've got
Mm-hmm.
butt pain. But is it reproducing your shin pain? Because there are some issues in glutes that if you sort of poke around, you can reproduce symptoms, whether it's foraminal stenosis or just a hypertonic muscle, you will get relief there. So I had her do a right side bend. That was the first thing off the bat I did because I figured
Mm-hmm.
that was going to be positive, and it was.
Mm-hmm.
Right into the shin.
Yep.
All other back bend. I mean, she didn't really have a back bend. Side bend left, forward bend, all pretty okay. I mean,
Mm-hmm.
not surprising. I mean, I didn't really. I had her do. So what was interesting, and I'm going to ask you. I'm just trying to think if there's anything else I did initially. I did a bunch of stuff, but I want to just go through this methodically. I did have her stand on her left leg, which obviously was much harder than her right. Because I was explaining to her that she lives on her right side, her body schema, just she's not used to being on her left. So it's going to be harder. Their muscles are not being used. They just can't adapt. So that was definitely harder for her. I actually had her squat. So I said, sitting makes you feel better. Show me how you sit. Show me how you squat. And when I tell you, Susan, when she squatted, her entire, you want to call it scoliosis, pelvic shift, everything corrected. I mean, it
Mm-hmm.
looked, she squatted, her pelvis went back, I mean, she was beautiful all the way down.
Did she do the same thing when she sat down?
Yes. And
Mm-hmm.
I said, you need to be doing squats. I mean, right off the bat, I'm like, you correct yourself in squat. I mean, it was unbelievable. I mean, she
And
was
no
able,
symptoms.
no symptoms. And I said, and I know her right foot was a little rigid. I said, you're not going down. You can't go down a lot because it's okay. I need you to get on your left side anyway. So if your
Mm-hmm.
right foot is rigid when you're squatting, that's actually not a bad thing because
Mm-hmm.
you're getting off that right side to squat down to equalize your weight bearing. So that stiff right foot in the squat didn't matter to me
Mm-hmm.
because it actually needed to get off that right leg anyway. So I told her to do a lot of squatting. And so I had her up against the wall. Lately I've been, if I find something in the eval, like I'll just
Mm-hmm.
have them do a few,
Yeah.
just to see. I don't sort of go through the whole thing, and then do it. I kind of do it in the whole session, like during the evaluation. So had
Mm-hmm.
her hands on the wall and I had her just squat all the way down. And she was really it was really interesting for her because she's like, I'm on my right leg. That's really interesting. And so she understood that, and I think she was aware of it. And so when I videoed her and I showed her how she squatted, and she basically was pretty okay. So I said, that's what you're going to do just to start off with. And I'm still evaluating her at that point. So do you have any comments or anything like that?
No, no, I like it because I was going to ask you if you actually had her stand on her left leg or if you shifted her, what would happen and did her pain reproduce, and it didn't. So
No.
that makes a lot of sense to me, which is really good because you definitely have movements that she can drop into
Yes.
that
Yes.
can actually help her.
Yeah. And
Because
be
it
good for
sounds
her.
like to me she's developed this shift to try to get off of that uh, nerve root.
Yeah. Yeah.
Especially since right side bending increases the pain
Yep.
down. So it's an effort to get off of it. But so is flexing. And if she was able to do it and drop into a squat and flex down, then those are really good reset exercises for her.
Totally. And I had her do a narrow base squat, very narrow, feet like ankles touching squat. She was pretty good. I had her do a midland level squat, pretty good, a wide base squat, all good. All squatting was good. She got off the right leg, centered herself, and she was beautiful. So I said, you should really introduce your variance into your squatting. You should go, hold on to the wall. It's not like and I'm not doing this, for quad strength here. Hold on to
Mm-hmm.
the wall, get your, close your eyes, get your sense of center, and you can squat narrow, mid, wide. And that actually was the first thing I gave her as a movement progression. And I wasn't even finished with the evaluation yet. But I
Right,
said,
but those are great loading exercises too.
totally, especially. And I
So they're going
said,
to be
and
good for her.
yes, and I
Mm-hmm.
said it's going to, standing on one leg wasn't meaningful for her. I said, but you'll be able to stand on that leg better once this left glute starts to wake up. You don't necessarily need to sit and do butt kicks or glute exercises
Mm-hmm.
like on all fours or, some of these bar classes. And those are good. But I said, for you, you need to be able to get on that left leg. And,
Mm-hmm.
squatting does that, and that will just wake the glute up anyway. You don't, if you're going to stand on your right leg and start, doing your glute exercises, at the end of the day, it's not going to really strengthen your glute. It's going to really reinforce a bad motor pattern. I mean, I didn't use the word bad, but I used like a
Right, right.
non-optimal.
It's definitely gonna feed into the faulty motor pattern because she's on her right leg all the time and she's symptomatic. So
Correct.
why would you want to stand on the right leg and work the left leg? That
Exactly.
makes no sense whatsoever. But if you want to get her onto the left leg, because walking, she needs to be able to stand on either leg. She needs to, start to incorporate that weight shift, and that's what the squatting and the flexing have done for her. Is they allow her to do that without having to overthink it.
Correct.
You can just actually do it, and as she becomes more aware and a little bit more mindful about how she's moving, hopefully she'll migrate towards that left side a bit more and start involving that left side,
Yep.
the activity of interest, which is walking.
Correct. So I had her do exactly. So I think it's important to note that, with her, it's not about doing the glute. It's just literally getting the weight over, and that's going to fire it. And that's how you're going
Mm-hmm.
to strengthen those glutes. Um, I just assessed her because she had, told me that in Colorado they did a lot of work on her psoas. So I went in and sort of poked around, and I didn't feel anything, to be honest. And then I took a look at her gastroc and her peroneals, and just to see, because you could see in standing they're really hypertonic, and it's like it makes sense. You're
Mm-hmm.
on that side, their muscles are just going to keep firing and firing and
Mm-hmm.
firing. I assessed her foot. She had some hypomobility in her midfoot. Not surprising. I ended up looking at her just straight walking, just gait normal, and shift to the right, shift to the right, shift to the right in the pelvis. So then I just had her do a step forward task, like literally step forward with the right foot and just lift the back heel of that left foot up like she's going to step forward, but she's not.
Mm-hmm. Mm-hmm.
And I saw the whole thing, the right pelvic translation, the lateral tilt on the
Mm-hmm.
right, the increased weight bearing on the outside border of her right foot. So then I said to myself, well, you can't squat when you walk. Let me try I have a Diane Lee's compressor belt, and I needed an extra set of hands. So I took the belt, and I centered her. I got her off. I had her hold the belt, and I had got her onto her left leg, and I had her just wrap the front part of the belt tightly. And then there's 4 straps on the belt. And what I
Mm-hmm.
did was I did some compression patterns and see which looked better, because I wasn't reproducing her symptom at this point. So I tried some different compression patterns, and I had her walk. And what looked the best and minimized this pelvic translation was bilateral anterior compression. So she had the pelvic belt on, and then I put the 2 straps on both sides that, sort of mimicking maybe decompression posteriorly or support anteriorly via the use of abdominals. But that's not why I did it. I wanted to see
Right.
why, if I
You
could
just wanted to
correct.
see what input would change her
Correct.
movement pattern, and the belt's a great input because
Yep.
it's all it is sensory input.
Yep.
And yeah, play around with it. And so that's great that it helped because
Yep.
it can help her gain some automaticity.
Correct. Correct. So she walked around, and she still had a little bit of a shift. I'm not expecting to take a significant shift away overnight like that, but it definitely minimized a lot of that. And she has to walk for a long period of time for her to feel those symptoms. So I couldn't really reproduce it. uh, so anyway, I explained to her, she's like, should I get the belt? I said, if you may, you may, because if you're going to be walking for a long distance, see if it helps. It's not something that you need long term, but I did it for diagnostic purposes. I wanted to see if I could take away the shift quickly with the belt. And she got that. She understood that. So that was the first visit. I'm thinking if there's anything else that I did. That's pretty much it. I mean, the first visit, that's what I sent her home with, squats. I had her do squats, and then I had her, when she was walking, to notice that she was putting a lot of weight on her right leg. So she came back like a few days later and said she's noticed that when she walks, she's really putting the weight on the right leg. So she's trying to equalize her weight bearing out while she's walking. So
Did that change your symptoms at all?
yes, she felt better.
Oh, good.
Yeah, she felt better. She said, let's see, I'm trying to think one day she didn't feel so hot. I'm trying to think why. I don't remember. But then the other 2 days they were pretty good. I think when she's more conscious of it, she feels better. And I think she actually had like a tight pair of pants on, and she said that she felt better with a tight pair of pants. It's like, well, that doesn't surprise me either. The belt
Yeah,
helps.
the
So
input. Yeah.
exactly. So what I did was, on that particular occasion, I added um, squats with, not squats, like facing the wall, hands on the wall, and just weight shifting to the left as another
Mm-hmm.
input. Okay, she could do it in the squat position, although she rectified it in the squat neurologically. So I just had her just stand and shift that like 30 to 40 times, because that I needed that. And so what I ended up doing, I played around with the belt again. I re-changed the compression patterns, and she preferred a different compression. But I ended up just doing a lot of gait with the belt on, doing some weight shift with the squats. And then I decided, because I've been into this dynamic functional release work, I assessed her step forward again. I had my hands on her glutes, and I'm curious as to what you think of this, because I had my hands on her glutes. I just had my thumb like on her glute minimus, just to put my hands on her, right? So I said, step forward with the right leg. And she reproduced her symptoms. She's like, what are you pressing on? I'm like, oh. And I got my hand on her glutes. So I was pushed harder. She's like, oh, you're reproducing my symptom. I'm like, oh, that's interesting. So I had her step forward a little bit more with the right leg, and I was just sort of poking around back there and trying to sort of not soft tissue it, so to speak, but almost like, I can't explain it. Almost like help facilitating the movement pattern, a better movement pattern. But I happen to have a thumb on a muscle that was really sore and potentially reproduced her symptoms. Let me know what you think about that, because I've been doing a lot of functional release, although that wasn't really a release. It was more of an exploration, I think, on my
Mm-hmm.
part.
Yeah, it just sounds like you were on her pelvis and helping her
Mhm.
move differently and seeing what happened. And some
Yeah.
movements didn't feel so great. Other movements probably felt better.
Yep.
But as you were kind of going, you were actually, it seems to me that you were actually just feeling kind of the activation pattern that she would get into
Yep.
that definitely reproduced her symptoms.
Mm-hmm.
So it gives you the ability to kind of have her, can you do this movement without reproducing your symptoms?
Right. Right.
So
And
if you go this way, it reproduces your symptoms, whether my thumb's here or not.
right.
Let go a
Correct.
different way, see what
Right.
happens.
Right.
What
Right.
if you just edge over this way, or you go this way, or you find it this way?
Yep.
Begin to get that to change a bit.
Right. And I know in the past, I said, well, do they do release work with you because I checked everything in side lying and supine and in prone, and I didn't particularly feel, I definitely, I mean, when patients say, my glute bothers me, I mean, you have to feel their glutes. They have to be felt, right? And they want to be heard and felt. So I pushed, I'm poking around, not reproducing anything. And then when I get her in standing, the second visit, I start moving around, and then in the step forward position, I definitely get it. And she wanted me to, put an X on the spot. I was like, fine, I'll put an X on the spot. And you want to sit there and put a ball behind there? Fabulous. Go for it. Go to town. If that makes you feel better, because it potentially could for her. So then what I also did this time is I went to her foot, because although the squatting got her off her right foot, Squatting wasn't meaningful for her. Squatting's a good movement exercise for her to reset her system and to change her brain, okay? And to get that brain, quote unquote, focused off that right side and getting it more to the left. But when she steps forward, you need to get some mobility in that midfoot. You need to supinate you need to pronate. You need some fanning in that midfoot. You need that arch to drop a bit. And it was very, very rigid. So I actually went to her foot and actually treated it on the second visit, because I felt that with the pelvis and the belt and the squatting, that's really helpful, okay? But her main issue is walking. Whenever I have a patient who has a problem walking, I will look at their squat and I will look at other things, because step forward is very hard to assess as a therapist. It's very hard to assess it. You can look at it visually, but it's hard to sort of sit there and put your hands on their feet, because the minute they lift the foot up, they've lost it, So I will find the driver in other positions, and then I will correct it and treat it and see if it makes it feel better in their meaningful movement, which for her was the step forward. So I went into the foot. I went into the bottom of the foot and did some release work on the intrinsics and, and some of the posterior tib and some of those other muscles in the midfoot, the anterior tib. Then I mobilized. I just did some mobilizations to her talocrural joint, just, for input. And she felt pretty okay, actually. I had her stand up, and then I had her take a step forward. And her pelvic shift, I don't know whether it was neurological, because this woman's a quick learner, or it was the footwork, or both, because when
Mm-hmm.
she got up and she did that step forward, it was like, oh my God, it was so much better. So then what I did is I taped her right foot, because once again I needed to get my hand somewhere else. So I taped her right foot in the tape that I talk about here bazillions of times. It's the calcaneal distraction. I start at the medial border of the medial heel, and I distract it and bring it around. That's the tape that I did for her, to see if it would give her more of
Mm-hmm.
a neutral rear foot, give her some more, I don't like the salsa, but just give her more of that fanning
Mm-hmm.
in gait when she takes that step going into mid stance. And it did. It actually did. And I'm not saying her foot's the main issue. I don't think it is, but I definitely think it's a
But it's a different
particular
point of
driver.
input. Yeah.
Exactly. Exactly.
There may be multiple main things going on. Sometimes we don't find there isn't a main thing. It could be just accumulation of, I mean, she's been walking like this for a year,
Exactly.
so that motor pattern's firmly established. And sometimes it just takes some different inputs to help begin to find ways to bring variance into that motor pattern and begin to change it.
Yep.
And which is why smaller walks probably feel better and longer ones feel worse, because after you walk for a long time, you're just going to drop into that big motor pattern again.
Exactly.
And if there's a pain output associated with that motor pattern, you're going to get it every time.
Right. And I said to her, I said, your right foot just can't adapt. The longer you walk, it just can't adapt. I said, squatting is great because you need to get off of that right side, and it definitely gets you off that right side. But when you're
Mm-hmm.
walking, you need to step on that right foot. And if you continue to do squats, yes, your brain will change, and that will carry over into other motor patterns for sure. Which is why I'm telling you to squat and continue to squat. But sometimes there are little secondary issues, like a foot, like a
Mm-hmm.
pelvis,
Mm-hmm.
that need treatment, just because you've just lost options. Your foot's
Yeah.
lost options, and
Need some
you
different
know
inputs. So I'm
exactly.
curious, how far can she walk before her symptoms start?
Literally about an hour, she told me, which is
Okay.
long,
Uh-huh.
which is
And
actually
she was
long.
walking longer than an hour most of the time?
No, but it depends. In New York, I think because the streets are harder than Denver, it doesn't take her long. I mean, I would say 10, 15 blocks. In Denver,
Okay.
it was definitely longer. Maybe she's walking in a park. Maybe she's walking on a softer surface. Maybe.
Yeah. And if we're going to go, one of the things that I would think about too with her is dosing,
Mm-hmm.
that she needs to stay under the pain limit,
Yeah. Yes.
because if she keeps walking into the pain, she's going to keep that motor pattern going. And maybe you can use some of the dosing to kind of help her a little bit. Look, if 10 to 15 blocks is your limit,
Yep.
then plan your walks for 9 blocks.
Right.
And that's when you start, plan it out so that you can stop and do something for a bit. You can walk again for a bit, whatever, but dose it out. So
Yeah.
because what you don't want is for her to kind of keep pushing to that envelope and getting right into that, okay, now it's hurting again, now it's hurting,
Yep.
and just keep confronting it and pushing through it because it's just going to keep the pain behavior going.
Yep.
But
Yep.
if she can, block it out and look at this as far as dosing goes, then that can be also of tremendous help. Be mindful, think about all those things that you're talking about with her,
Yep.
just kind of automate, get over on the other side a little bit, do that, but also pay attention so that you're not continuing to push through the pain.
Mm-hmm. Mm-hmm.
And you're not, it's kind of like always retesting to see if the pain is still there.
Yeah.
It's like, nope, just stick it 9 blocks for a while, if
Yep.
she could possibly do that
Yep.
and work on that, or take the subway some,
Yep.
so that she's walking some blocks, but she's sitting some, she's walking some blocks, she's sitting some.
Yep. Yeah. I think that's a great idea. She's with people like her. I mean, she, quote unquote, had a scoliosis. Is it a scoliosis? Maybe, but I correct. It's. I don't think it's structural. I mean, she definitely, it corrected pretty quickly with the squat and with
Yeah.
some input and support. I think a lot of people, they feel very good when they get, quote unquote, I'll use the word release, soft tissue massage, any kind of soft tissue work. It may make you feel better, but, and I'm, this side is like my soapbox. If you continue to do the same movement pattern over and over
Mm-hmm.
again, that release work is a waste of your money and your time. Okay, it may make you feel good in the short term, but you're
Mm-hmm.
going to get what you always got, which is
Well,
pain
it's
and
been,
dysfunction.
yeah, it's been going on a year and it hasn't changed.
Right,
So,
exactly. And I'm all for manual therapy and all getting that in there. And trust me, and if I would do that. She needs both. She needs both.
mm-hmm.
What I have found that is missing with a lot of these people who have this persistent issues are not getting the right movement program,
Exactly.
and that is a big thing. And I, I'll work on psoas and glutes, whatever, and foot with the best of them, but until you get the right movement program, like with her, it takes some good clinical reasoning, because with her, you're going to do glute exercises standing on the right leg. That's the worst thing that she could possibly do, right? So I would challenge our listeners that think sometimes, when you're giving someone an exercise, why are you giving it to them? Does this fit, is this going to get them where they need to go in terms of, like, for her, she needed to get off her right leg, absolutely needed to do it, so is an all fours exercise to start with, maybe to start with, but at the end of the day, if you can get them in a loaded position and they can control their movement really well, that's where you go. And I mean, standing, facing the wall with your hands on the wall is not a really high level activity here,
Mm-hmm.
So the glutes will automatically turn on. I mean, yes, they maybe need a little bit more input, but just doing that and getting the weight on that left leg is going to start to fire the glutes. Whereas if you put them, I'll reiterate it again, standing on one leg, doing kickbacks and hip extension and glute max, and that's just reinforcing that motor pattern that you don't
Yeah,
want.
exactly like we talked about. If it hurts to stand on the
Yes.
right leg, why are you going to stand on the right leg and move the
Yeah.
left leg?
Yeah, and are you going to get them doing
What are they not
clamshells or hip
doing?
abduction? No, I don't think that would have helped her either. It
No.
may be early on, like maybe 2 weeks into her symptom, but this is like a year. So you're having to lie on her right side. I'm sorry, lie on her left side or lie on her right side and do clams and hip abduction, and you know, uh, I just don't think that's going to give you the best bang for your buck. I always tell
Right.
people, how many minutes do you have for exercise at home? I've got 10. The best one was a squat. That's the
Yeah.
best one, and all the different Y base. And if you want
Mm-hmm.
another one, we'll think of another one. But people don't have the time to do all of these exercises, and
Mm-hmm.
I think that's not a sound. Clinically reasoning through that, you got them on your side. Yeah,
Yeah.
maybe.
How is that changing their walking?
Exactly.
I'm all for I'm all for exercise and moving in a lot of different positions and getting in different sides and doing all that. But at the end of the day, strengthening a muscle laying on your side doesn't necessarily mean it's going to travel over to the motor pattern when you stand up on your feet.
Right.
And we
Right.
have plenty of evidence with motor control and motor pattern regeneration and all of that kind of stuff from neuro and sports that we know that that's not, um, it's just not a great, most optimal way to really recover those types of things. The best way to recover these, what they call closed loop type of movements, is to get them into the movement
Yeah.
and change the movement within the movement and not break it down into these pieces and parts all the time,
Yeah.
but to give the input in and put it back into the movement like you did. You did some stuff with the foot, but you put her back into the movement. You did some
Yeah.
stuff with the pelvis, but then you had it go into the movement.
Yeah.
You had her pay attention to how much are you on your right foot, and you put that back into the movement. So all of that went right back into the movement pattern. You were trying to help recover for her and bring variance to the pattern in many different ways. And then you found a great reset exercise that took her pain away.
Yeah.
This was the squat.
Yeah.
So when she hurts, stop and squat,
Mm-hmm.
and do that, or stop and sit for a bit if you have
Yeah.
to.
Yeah.
And then I think the only other thing that I would add to all of this, Erica, is just the dosing.
Yep. Okay.
The time walking, so that she's not continuing to push through. She's becoming so aware of everything else, she can become aware of that too.
Yeah. Yeah.
And just like, hey, and then if you respect that, you're going to actually begin to start increasing the number of blocks you can walk,
Right.
because, you're settling things down,
Yeah.
and you're still moving, and you're still doing, and you're still making all that happen.
Yeah.
And then you'll be able to start increasing up to 10 blocks, and then 11 blocks, and 12 blocks, and then, you
Yeah.
know, and that kind of thing. And I think that could be, one of the other pieces that could really help her.
Yeah.
She does have kind of a finite, I can walk for a certain amount of time, and then it becomes too much.
Yeah. Yeah.
Hmm.
For sure. Um, I mean, she's failed how many epidurals? I mean, at this
Yeah,
point,
and
it's
that's not
just
helping her.
no. I mean, it's definitely so. The dosing, that's a good idea. I mean, I think just to progress her. I mean, any thoughts on progression after this? I mean,
Um,
she's gonna squat and do her dosing,
yeah,
and
my thing with her is, I'd really do the dosing and the walking, and really start getting her to be really aware of how far she can go
yeah,
before it hurts, and really start working, because that's a great thing for her, and she likes to walk.
yep,
The other thing you could do is, you could, if she's interested, I don't know if she's interested or not, but she could start loading, some of the movement patterns that feel good.
yeah,
It's going to be good for her osteoporosis and her stuff.
yeah. Put some weights in her hand. Yeah,
Yeah, so, some weights in her hand, or, maybe even a weight on her ankle. I don't know. You can
yeah,
try it and see,
yep,
but just giving her a little bit of resistance work too, for looking at her overall health. If she's that osteoporotic, that she's had all these falls, and she's had fractured wrists and a fractured humerus and a fractured, ribs, the system needs to be loaded a bit,
yep,
as well. And just make sure that the walks aren't, that she's not one of these people that are just like trying to exhaust themselves with exercise.
yeah, yeah. No, I
Like,
think she's okay.
yeah, that sometimes less is a little bit more in these situations,
Yeah,
and allow the whole system a chance to adapt a little bit more.
yeah. I like the weights on the ankles.
Mm-hmm.
I've used to do that quite a bit, and I haven't done it in a while, and I think that's a good idea because
Just see what the input does to her. It may make it
even it,
great. It may not make it. We have no idea.
yep.
Maybe just the left. I have.
I was going to say I would probably put it on her left to get her
Yeah,
more aware of that left side and have her walk a bit and
yeah.
see.
Just see what happens. Yeah, I
Yeah.
mean, it's great input. Carrying some weights are fine.
Yep. Totally. Yeah.
You know,
Yeah.
just avoid things that have her lean to the right.
Yep.
So if she's a right-handed purse carrier, maybe she needs to do something different there.
Yep.
Because that could free things up, or it may keep her more on her right side. So just kind of looking at those peripheral type things might be something fun to kind of do and challenge her with, and
Yeah.
seek her input. Like,
Yeah.
you tell me, what do you think?
Yep.
Where do you
Yeah.
think this needs to go? What would you do now that you know what you know, so she can start really beginning that problem solving thing with you?
Yep.
Well, I
Yep.
think if I put this over here, I don't know. I've never tried it over here. I don't know if I could carry it over here. Let me see what happens.
Mm-hmm.
And then you can kind of get her a little bit more involved. Like, here, let's try a weight. Which side do you think you should put it on first?
Yep. Yeah.
And just see
Absolutely.
what she comes up with, and let her kind of like, because now you're giving her permission to explore and play too,
Yep.
which will be fun, because she sounds like she's already done some of that. I realize how much I'm on my right leg
I
now.
know. I know. It's funny.
And so, boy,
Yeah.
when they have that insight, it's so much more fun, because then you get to really kind of like partner with them and say, you walk consistently. You're telling me that 10 blocks seems to be about the time when you start to hurt.
Mm.
What do you
Yep.
think about that? You know, and then just have them kind of like talk about it and
Yeah.
see like what
Yeah.
would happen. And then you can actually say, what would happen if you only walk 9 blocks at a time?
Yeah. Yeah.
And see if there's what she thinks about that, to go through and but those would be fun things to do, and it would help her, her overall metabolic health as far as, her osteoporosis and some of her bone health
Yeah.
stuff.
Yep. Yeah.
For
Yeah. Yeah.
sure.
For sure. Cool. Well, that's it. I've only seen her twice.
Awesome.
She may go back to
Yeah.
Denver, but it's. I thought it was a great case to talk about because of the quote unquote scoliosis, which I don't think really is scoliosis, but and it was good because this is a very typical presentation you see a lot of, especially in this
Mhm.
age group, and
Yeah.
it's important to sort of look at everything. So,
The other thing that you could probably start doing too, as you kind of move her forward a little bit
hmm
and kind of really get this down a little bit better, is really start getting some rotation into that system.
right. Yep.
Because she's had, what, 3 falls already?
Yes. Yeah.
Yeah.
Yeah. And she's young.
Yeah.
She's
She's only
67.
67.
Yeah.
Yeah.
Yep. I
So
agree.
rotation, rotation, rotation,
Yep. I agree 100%.
getting that in there too,
Yep.
and seeing where she can rotate and where it's comfortable and where it's not, and
Yep.
if that bothers her or not. So that could also help
Yeah. I mean,
facilitate the foot and the pelvis a bit.
when you look at the history with the three failed epidurals, is it really the nerve root? I mean, usually people
Yeah.
tend to get some relief. She got zero,
Hmm.
and
Well, it's not an
that's
acute inflammatory response.
correct. That should clue you in right there. So,
Hmm.
um, cool, awesome. Well,
Yay.
thank you, everybody, and we'll see you on the next podcast.
Yes. Thank
Bye.
you.
Thanks. Bye.
Bye.